In March 2020, COVID-19 was declared a global pandemic by the World Health Organization. Offices shut, travel slowed down, the world moved inside. But development doesn't stop. As the world changed around us, the global development industry rapidly adapted to the new normal. From overcoming global supply chain disruptions to increasing access to remote learning, from jump-starting digital solutions to finding new ways to connect with the communities where we work. The cooperative, innovative, and resilient spirit of the global development industry ensures the progress, safety, and well-being of our global community. In challenging times, development works because we work together.
Hello, and good afternoon and good day, wherever you may be. I'm pleased COVID has had a huge impact on us over the past year, and it is basically one of the bases for our foundation of Mind the Gap, and one of our issues that I think that we all have realized that there's been no lives untouched over the past year by the pandemic. It's been hugely disruptive and has had huge impacts on health, education, access to livelihoods, among so many other things, and brought deep sorrows and pain to many people across the world. And in many respects has heightened all the inequities that we've seen over the past years, whether it's access to education, increased gender-based violence, and just vaccine equities and access to healthy vaccines. And so I'm particularly pleased to be opening this session today and introducing my colleague on the SID-Washington board and co-chair, Ann Simmons-Benton, who will be the moderator for this panel. And I will hand it over to Ann.
Thank you, John. And it is indeed my pleasure to be introducing and moderating this panel. First, I'd like to introduce Jeremy Konyndyk, who serves as Executive Director of the USAID COVID-19 Task Force and a Senior Advisor to the USAID Administrator. He oversees the development and implementation of USAID's COVID-19 response efforts and leads the agency's engagement with foreign government counterparts, partner organizations, and global response institutions, including Gavi, COVAX, the World Health Organization, and the Global Fund. And he recently rejoined USAID in January 2021 for this very important job. From 2017 to 2021, Jeremy was a Senior Policy Fellow at the Center for Global Development, where again he worked on COVID, and he co-created the COVID Local Initiative to develop a frontline guide for use by city and community leaders. He also led research initiatives on pandemic preparedness, humanitarian effectiveness and reform, and U.S. development policy. And previously to that, Jeremy worked at USAID as the director of USAID's OFDA. He currently serves on the Independent Oversight and Advisory Committee for the World Health Organization's Program on Health Emergencies. I'm also delighted to introduce Anil Soni. Anil is a leader in global health who has worked for 20 years in the public, private, and nonprofit sectors to expand healthcare access in low and middle income countries. On January 1st, 2021, he became CEO of the WHO Foundation. Anil joined the WHO Foundation from Viatris, where he served as head of global infectious diseases, working across the pharmaceutical company to accelerate the availability of new and innovative treatments. Anil was closely involved in the early years of the Global Fund to fight AIDS, tuberculosis, and malaria, serving as the advisor to the executive director, and then as the founding executive director of Friends of the Global Fight. He served as the CEO of the Clinton Health Access Initiative, where he worked from 2005 to 2010 and oversaw the rapid expansion of the organization. Anil has also been a senior advisor to the Bill and Melinda Gates Foundation and the MDG Health Alliance. We are in such great hands here today for this conversation. And I note that both of you have taken on these important jobs just in January, 5 months ago, in what is the world's most pressing problem. So, Jeremy, I'm going to start with a question for you. You've returned to USAID to direct the agency's COVID task force. Can you tell us about that work? How is the task force structured? And what are your primary functions and goals?
The core purpose of what we're trying to do through the task force at USAID is to follow the president's policy guidance that the aim of the U.S. government here is to beat the pandemic. And so we're approaching that in a number of ways. We're kind of looking at that through kind of three big lenses. One is, we need to beat the pandemic by beating the virus itself. And so we are making a big push on global vaccination. The president announced recently that the U.S. would begin sharing vaccines, but beyond that, we're also providing support to the COVAX platform that's organized by Gavi, WHO, UNICEF, and others. $4 billion will be going through that platform per the congressional appropriation last year. That makes the U.S. The largest single donor. And we're also pursuing other forms of support to ultimately to try and vaccinate the world. But we also know that beating the pandemic is not just a matter of vaccines. The vaccines are going to take some time to come online. So in the interim, over the coming months and into next year, while the vaccine production globally is getting to the scale it needs to, we're also making a big push on supporting clinical and public health interventions to try and reduce transmission, bring cases down, and save more of the lives that can be saved through improved clinical treatment. So that's sort of the basic idea on how we're trying to tackle the virus itself. But we also recognize the impact of this pandemic is not just through the virus. It's also having a lot of impact resonating across really every development sector, everything that AID does. And so we're working on the humanitarian impacts, working to prevent famine through our Bureau of Humanitarian Affairs assistance, working through our education programs, our economic support and livelihoods programs, to address some of the other acute human impacts of this pandemic that go beyond the health space. We're also very aware of the systemic risks that are being posed by the pandemic. So, you've got a human level of those secondary impacts, but also we're seeing the pandemic putting into jeopardy systems of governance, sparking increased conflict, obviously posing threats to economic systems. So intervening both through USAID and through some of our interagency partners to try and better address and mitigate some of those potential systemic risks being posed by the pandemic. And then the third big piece is, we also are going to beat this pandemic by coming back stronger than we were before. And so we are looking forward and working closely with colleagues at HHS and at the State Department and the White House on building and strengthening the global architecture for pandemic preparedness, so that even as we're working to defeat this pandemic, we are getting ourselves more ready and beginning to apply lessons so that we can prevent or better manage the next one. And so we have built this task force within USAID because this is not just a health issue. It's not just a policy issue. It really is a whole of agency issue. And so we have set up a whole of agency task force that I have the privilege to lead that is working to mobilize the whole of USAID around this mission. And when I first came in, I was on the first wave of appointees after the inauguration, and began consulting really intensively across the agency in those first few weeks to understand what needed to happen and how were people seeing the challenge of COVID. One of the things I heard over and over was that this is not any one bureau. This is not something that can only be owned by a task force. This really is core business for the whole of the agency. It is touching everything that we do. And not just touching all of our programs, but also touching our people. This is both a kind of program and intervention delivery challenge, sure, but it's also, as we're all experiencing, a day-to-day life challenge for our workforce. And so the task force that we set up is not just focused on delivering on USAID's mission, it's also focused on supporting USAID's people. And so we have an emphasis on workforce support within the task force as well. So that's the approach we're taking.
Well, thank you very much. That's great to hear that. And thank you for being there. Anil, some of our participants in today's conference are probably not familiar with the WHO Foundation. We do have participants from over 60 countries. Can you describe for us the mission of the organization? And I know you've only been there for 5 months. Could you also tell us what attracted you to the foundation, particularly at this time?
Yeah, of course I can, and thank you for the question. And as you mentioned, you have participants today from all around the world, and many of you, all of you, are global health leaders and workers in your own right. And it's a privilege to be with you. And part of what we want to do with the WHO Foundation is actually listen to you and better understand how the WHO can better meet the needs of its stakeholders. Let me rewind a bit to answer your question. I've spent 20 years in global health, many of those years at the Global Fund, at CHI, in industry, in the public, private, and nonprofit sectors. And across my entire career, the WHO looms large. No one can do quite what the WHO does in terms of norms and standards, guidelines to prevent and treat disease, pre-qualification, the leadership it provides at the international and national level in terms of preparedness and response to pandemics, and building the health sector to achieve health for all. The WHO has existed for 70 years as a part of the United Nations, as a member state-driven organization. It has not, however, had a close relationship with the private sector. And part of the reason why is because it needs to protect its normative role and avoid any real or perceived conflicts of interest. That distinguishes it from other major UN agencies, which receive quite a bit of support from individuals, from philanthropists, from foundations, from corporations and corporate foundations. And the intent in creating the WHO Foundation, which preceded COVID, was to create a platform by which all of those stakeholders could more closely engage and support the work of the WHO. So the WHO Foundation was created legally a year ago in the middle of the pandemic as a Swiss foundation. We are not part of the United Nations. We are not beholden to the World Health Assembly or the management of the WHO, but we are part of the family. And what attracted me to the opportunity, frankly, was a year ago when there was critique of the WHO. I recognized that critique. I've spent a lot of years wishing the WHO does its job better. Not that it's not doing its job well, but the better the WHO does its job, the more we all benefit. And last year, when the then U.S. president took a critique and it led to this thinking of withdrawal, I really wanted to do the opposite. I wanted to lean in and make sure that I was playing my part to support the WHO moving in the direction of transformation, reform, innovation, and greater impact. And that's what the WHO Foundation is intended to do, to be a partner to the World Health Organization, to co-create programs that are going to tackle ambitious areas like structural racism, climate, digital health, primary healthcare, mental health, and use external finance to, as one colleague at the WHO said, potentiate the work of the WHO. So over the coming years, the goal is to raise a lot of resources and to use those resources to have outsized impact with and through the WHO. But this year, as we're all talking about, we have to, as I've said, build the ship while we're sailing it. In other words, yes, we are going to build for the future. Yes, we will design those strategies to do things in those areas. But in the meantime, we have to have all hands on deck in the response to COVID-19. And we focused in a couple of ways this year already in the first 5 months. One is to continue the tradition started by the United Nations Foundation last year to raise corporate and individual resources to support the work of the WHO to fight COVID-19. The WHO is, of course, one of the partners of the ACT Accelerator, the Access to COVID-19 Tools Accelerator, which is the multilateral organizations that are leading the fight against COVID-19. And that work is urgent. It's also an economically good investment. Just this week, there were new studies that came out, and the International Chamber of Commerce put some work out earlier this year that said it's economically self-defeating to not fully fund the ACT-A. Because we live in a world that depends on interdependence and global trade, if we're not fully funding the ACT-A and the pandemic continues to exist and thrive in some parts of the world, that's going to affect the global economy. That's going to cost businesses money. So this is actually a case in which businesses giving to the ACT-A, to institutions like the WHO, is not just charity, it's an investment, and it's a good investment. So we've been soliciting corporate contributions to the work of the WHO and COVID-19. And secondly, just 1 month ago, tomorrow, we launched a campaign called Go Give One, which is a platform for everyone everywhere to give a small amount of money, just a few dollars, to buy a vaccine for someone else. The COVAX AMC, which is the fund that exists within the ACT Accelerator, within the COVAX pillar that's administered by Gavi, of course, it's receiving money from governments and corporations and foundations like the Bill and Melinda Gates Foundation. But this is a moment when everyone in the world is united in thinking about the need to ensure that everyone's getting vaccinated. And many people in privileged and high-income communities are getting vaccinated for free. Not to dismiss your tax contributions to the government, which is paying for those vaccines, but you're not necessarily paying out of pocket for a vaccine. And everyone, after they get one of their vaccines, is waiting, seeing if there's a severe allergic reaction, taking a selfie, feeling joy, feeling hope. And in other parts of the world, people are feeling quite the opposite. They're feeling fear and anxiety. They're in the middle of crisis. And we wanted to give individuals the opportunity to contribute directly to the COVAX AMC to help buy vaccines for others. So Go Give One and the Solidarity Response Fund are the two major priorities for us today to mobilize more resources, both to the WHO and to the COVAX AMC. And we'll be designing strategies going forward in the areas that I mentioned to help the WHO be more impactful and innovative going forward.
Oh, thank you. And I'm hoping our SID team is putting those links in the chat so people can go and contribute as soon as they are out of this conference. A question for both of you. The world has really been shocked to see the terrible tragedy unfolding in India. Can each of you tell how you see the situation evolving and what USAID and the WHO Foundation are doing to respond to the situation in India? And Jeremy, would you mind going first?
I'd be happy to. Thank you. Yeah, I think the situation in India obviously is a concerning. Well, I think the big concern is that this may be a bellwether for what we could see across numerous other developing countries over the coming year. And kind of going back to what I said earlier, the reason why we can't simply going to wait for the vaccines to arrive, that we need to continue collectively pushing on reducing transmission and supporting improved clinical interventions, because this, some of the data that's now coming out about this variant in India suggests it may be significantly more transmissible than even some of the prior generation of variants. There's some data in the UK that suggests that it is outcompeting in the UK the so-called UK 117 variant. That variant in turn was outcompeting traditional COVID. The dynamics that we've seen in India are very explosive, aggressive transmission and transmission amongst lower age groups, some more severe cases amongst lower age groups. And if we began to see that across other developing countries, and there are indications that that's, Nepal and increasingly Sri Lanka are now in a similar situation or on a similar trajectory. Well, that could be very devastating across numerous developing countries. And so we are scaling up our support to India. The U.S. has sent 7 plane loads of aid. We have also started up new response programming through the USAID mission there. We've put in so far, between the in-kind assistance that we have shipped in and the in-country assistance, we have programmed about $100 million in response funds so far. We have further funding coming that we'll be announcing in the weeks ahead as the mission continues to roll that out and work with the Indian government to support the response to this crisis. But I think what it really underscores is that no country is safe until we get where we need to on global vaccinations. And so we do need this 2-track push, pushing hard on expanding access to vaccines and pushing hard on public health measures to manage transmission and on measures to improve clinical care at the the hospital, the facility level, and so we're also, as we're working on the response in India, we're also then factoring some of this into the response that we're preparing to roll out more widely across the world. So we have new funds under the American Rescue Plan that we are we are on the cusp of beginning to roll out to our missions around the world that will be focused on implementing these two priorities, and in particular looking working on things like oxygen, because we've seen oxygen be such a major need in the South Asia response. There is more that we could do in a lot of other countries to get them ready, to get more of a medical oxygen infrastructure into place ahead of this wave potentially hitting them.
Jeremy, I have a follow-up question. If there are companies that want to donate, ventilators or oxygen, what would you recommend for them to do if they're a U.S. company? How would you handle that request? Where would you tell them to go?
Well, we have been working closely with the U.S.-India Business Council at the Chamber of Commerce, and they have set up a response hub for companies that want to provide support. We're working closely with them. I just spoke with them earlier this week with Nisha Biswal, my former colleague, who is now running the USIBC and has been. She said she feels almost like she's back at USAID these days, working on a disaster response again. But I think that's a great entry point. We also at USAID and at the State Department have private sector engagement teams who can also work with companies. But we're trying to channel a lot through the chamber, because that's a great first point of contact, and we're closely partnering with them. One thing I would say is that what we're finding is the oxygen peripherals in particular are in short supply globally. So one of the things we're also encouraging the business community is it's not just about shipping in supplies, it's also about trying to address the supply chains that feed the kind of materials that we need, and begin to hopefully build those out in anticipation of what could be a lot more global demand for oxygen equipment and peripherals in the months ahead.
Great. I think those supply chains are really important, but I come from the economic growth point of view in this conversation. Anil, can you talk to me a little bit about the WHO Foundation and how you're dealing with India right now?
Sure, happy to share a little bit. And first of all, just to echo what Jeremy said about India potentially being a bellwether, it's really sobering. And I hope everyone who is working in global health, economic development, COVID-19 takes a moment to realize this dramatic contrast between high-income countries or privileged communities that have access to the vaccine. Literally out my window in Geneva, there's outdoor dining and people are getting back to normal. They're feeling the associated freedom and joy of that. And India is on fire. My family in Delhi, they're not leaving their homes. They're trying to get their hands on oxygen just in case. There's no one there who doesn't know someone who's been ill or who has died. And if this is the beginning of what's to come in terms of new variants or rise in infections in other parts of the world, it is manifesting in no uncertain terms that this pandemic is not going to be over anywhere until it's over everywhere. And we have to act in solidarity to respond all around the world, as much as it is appealing to enjoy the newfound freedoms of those communities where you see high vaccination rates. So the India situation is urgent for those in India from a humanitarian perspective, but it's also urgent for all of us around the world in terms of how we respond to the pandemic. It is certainly, as Jeremy mentioned, made clear that we have needs globally in terms of medical oxygen and otherwise. What we have been doing at the WHO Foundation, as I mentioned earlier, is raising resources to support the work of the WHO. The WHO Foundation is not an operating foundation. The WHO, a third of it is emergency response. And that part of the WHO honestly is more like MSF or other humanitarian organizations, and they activate in partnership with the national government in moments of crisis and emergency. The Solidarity Response Fund, again, set up by the UN Foundation last year, is the way in which corporations can give directly to the work of the WHO, whether that be medical oxygen or temporary hospitals or staff on the ground, boots on the ground, tests, all of that work that the WHO is doing is funded through their I always hesitate to use acronyms, but they have a Strategic Preparedness and Response Plan, an SPRP. It's essentially part of the WHO that's funding COVID-19. The Solidarity Response Fund, which the WHO Foundation is now leading, is the channel into that work of the WHO. And within the first week of the crisis in India, we issued an appeal through the WHO Foundation. Again, thank you for putting into the chat the WHO Foundation's website. That's who.foundation, to allow individuals to give and to allow corporations to give. And just today, I'm getting messages that companies are contributing and making sure that they can help the WHO in its response, the WHO working closely with state and the central governments there, and all of the partners, some of whom Jeremy mentioned, to respond to the crisis. So our goal right now in terms of India is to use this as an opportunity to mobilize more resources for the global fight against COVID-19 and awareness that we have to tackle this pandemic globally, and to create specific appeals for corporations and individuals to help the WHO's response in India.
Thank you so much, and hoping your family stays safe as well. Jeremy, during this conversation, we focused so far on the health piece, which is natural, and of course, which is the thing that touches us the most at the moment. But it also is an economic crisis. Can you talk about some of the ways that USAID hopes to help with economic recovery once the pandemic is past us, or even possibly while we are during the midst of the pandemic?
Yeah, it's a really important question, and I would say it's not just about recovery from the pandemic's economic impact. It's also really important, even during the pandemic, to enabling the kind of public health interventions that are needed. As we've seen here in the United States, communities that are low income, or are kind of in jobs where they have very little flexibility, where households that don't have much of a safety net are going to be more exposed to the virus, because they will not be able to adhere to some of the measures that can prevent transmission at a community level. And so that is equally true in developing countries. So I think that one of the things that we're trying to be better at is viewing the economic interventions not just as something that, yes, is addressing economic need, but also as something that needs to be supportive of good public health interventions and transmission reduction practices. As we're looking forward, I think we're recognizing as well, this is not something that is going to go away quickly. So even after we hopefully defeat the virus, I am hopeful that over the coming 1 to 2 years, and sooner if at all possible, and we're going to push hard to shorten that timeline along with our global partners. But hopefully we will be at a point where the most disruptive effects of the virus itself are beginning to abate. And I think as the vaccines roll out and as the vaccines reach scale globally, that we'll start to see real improvements there. But I think we'll continue to see lingering economic impacts and lingering impacts on development portfolios for far, far longer. And so if you think back to the global economic crisis of 2008 and the simultaneous fuel price crisis and food price crisis, the development impacts of that lingered for years after the immediate shock had receded. And I think we'll see a similar dynamic here. So we're anticipating that this will continue to be something that shapes our long-term development portfolio probably for years after we have helped to bring the virus itself under control. And so we are beginning to look at our out-year budgets on that basis to begin to advocate for building in resources and pivoting some of our existing resources to take that into greater account.
Oh, thank you very much. Anil, I'm going to shift a little bit. The topic of our conference is Mind the Gap, but it's for equity and impact. I know in your career, you've been a strong proponent of health equity. What is this pandemic teaching us about health equity and the social determinants of health?
So, Anne, I'm going to be provocative in responding to that. I think it's showed us that we failed in the last 20 years to make real progress towards health equity. I have been humbled in the last few years, about the degree of inequity, structural racism, institutional discrimination, the lasting effects and legacy of colonialism on the space in which I work and on the organizations that I've called home. And I think part of what this moment, whether it be the disproportionate impact of COVID-19 on marginalized communities, whether they be tribes in Kenya, castes in India, indigenous peoples in Australia, New Zealand, or the United States, whether they be communities of color, the disproportionate impact of COVID-19 at the same time as Black Lives Matter in the United States. I know you have a lot of people calling in from around the world, but Black Lives Matter received a global response. There was a movement around the world to say this isn't just about one particular population in one particular country. We've failed. We have failed to really reckon with generations of injustice and their lasting effect on the ability for marginalized communities, for communities that have been the victim of institutional discrimination, to have a fair shot. This is not about discrimination as an individual behavior at the last mile of health to achieve health equity. There's a chair of a number of commissions on social determinants for health named Michael Marmot, who I spoke to in my early work at the WHO Foundation because I want to make structural racism a priority. And he told me in all of those commissions that he's really come around from 10 years ago when he said, yes, discrimination is a social determinant for health, which is sort of, apple pie, that yes, okay, that's easy to say, to acknowledging that the institutional discrimination that we have to tackle to achieve health equity is not necessarily even in the health sector. And until we acknowledge that, we're going to keep on failing. So I am working on an initiative at the WHO Foundation that would ask the representatives and leaders of communities who have been on the receiving end of institutional discrimination to advise on how the WHO can better acknowledge how we are complicit, all of us, in institutional discrimination in the global health ecosystem. I'll give you an easy example. I've spent 20 years working on expanding access to AIDS treatment, to antiretroviral coverage. We don't measure ARV coverage for the most part, at least at the international level in terms of how the Global Fund measures progress, by caste in India or by tribe in Kenya. And what does that mean? Well, if we're not measuring it, then how do we know that the 20% or 10% of people we always fail to reach, even though we always strive to do so, aren't the same ones who are already marginalized in every other way? So we're not measuring it. And I still think we have systems of governance, management, leadership, strategy that are relatively anchored in the global north as opposed to the global south. So I think what we've learned, or at least what I've tried to internalize, is that this isn't an area where we need to marginally make it better. And Jeremy rightly said, the legacy of COVID-19 is going to stretch years into the future. This is not a pandemic that's going to end and then all of a sudden we're going to go back to the way things were. And even if we could, doing so would be, in my opinion, a lost opportunity. I think we have to learn and ask ourselves, what did we see in COVID-19 that we need to respond to differently in the future than we did in the past? And to me, inequity, discrimination, racism, that is what we saw. We saw the outcome of all of those things institutionalized in the way that this pandemic affected some communities more than others. And my sincere hope, and I should say my commitment in my current role, is that we tackle that more squarely, not by asking ourselves what little more can we do, but by really looking at how we're complicit and how we need to do things differently.
I couldn't agree with you more, and that is really fundamentally the reason we asked the question, and what the whole conference is based on is that take this moment to pause, to think, to observe, and to really take action. Thank you so much for those remarks. Jeremy, I'm going to just go back a little bit to Ebola, because The question is, during the Ebola crisis, many of us hoped that development efforts around the world would evolve to emphasize health system strengthening rather than a focus on individual diseases. I'm not sure what happened. Do you think that coming out of the coronavirus pandemic, we can change the emphases of our health programming and build systems that are more resilient? I would say more equitable. And what have we learned about this pandemic that can guide us about how we think about health systems globally and build back better and more equitably?
It's a great question and a really important question. So I think first, we have seen some improvements on this since Ebola, but it is really striking how in crisis after crisis we end up during the crisis relying on systems that were built through vertical disease programs. So to give a few examples, during the ultimately limited outbreak of Ebola that occurred in Nigeria in 2014, I don't know how many people remember that even, because it was a sort of disaster averted. But there was a cluster of cases in Lagos. And obviously, as everyone on this call knows, that's a rather large city, large population, and an out-of-control Ebola outbreak there would have been devastating. The population of Lagos is larger than Guinea, Sierra Leone, and Liberia put together, or comparable to it at least. And that was averted. And how was it averted? Well, it was averted in large part because what the government of Nigeria wisely did, with support from the CDC, was to pivot the incident management structure that had been created for polio, for the polio campaign. So they took their polio infrastructure, they pivoted that, the contact tracing, the public health outreach, pivoted that towards COVID towards Ebola, and that was really critical to helping to contain that before it spread throughout spread elsewhere throughout the country and could have gotten much worse. We've seen similar things during COVID. So in many countries where PEPFAR has been present for many years, those countries have used PEPFAR-supported infrastructure and partners and capabilities in their fight against COVID. So using, for example, laboratory PCR capabilities that were put in place for HIV diagnosis, but which can be repurposed towards COVID diagnosis. And so diagnostics in many sub-Saharan African countries in particular would have been much further behind for COVID if not for those PEPFAR investments. So, we see over and over the ability of these vertical disease investments to be pivoted towards other diseases. And I think we need to grasp that more intentionally than we traditionally have. I think we have improved on that since 2014. The push towards investments in the global health security agenda has led to some improvements in country systems and intentional investments in capability to prevent, detect, and respond to outbreaks and epidemics, but not nearly enough. And there's not been nearly enough investment or resource support to countries to do that. So I think that is one of the next frontiers, is to both in our vertical disease programs think more intentionally about kind of multi-purpose use of some of the capabilities that we're supporting, and also to amplify our investments in broad global health security capabilities.
Wonderful. Thank you so much, Jeremy. Anil, I know that COVID is not the WHO Foundation's sole focus. What do you see as the biggest and most pressing global health challenges in the next decade? And since you're CEO, are you going to be able to weave in or use equity as one of the focus going forward?
Well, equity is going to be my first answer, but I think exactly as you just suggested, equity is not a program. Equity needs to be a lens through which we see all of our programs. So I want to, in terms of our priorities, first of all, part of how I think we integrate equity as a value into our work is to listen better, and to listen to the voices who don't have enough power and privilege. And so during the course of this year, we will be undergoing a strategy process where we identify what the strategic priorities will be for the WHO Foundation. In other words, what are the areas of the WHO's work that the foundation will make its priority to help raise external resources and help potentiate the work of the WHO. And we're going to get that work started in the next 4 to 6 weeks, and it'll go through the end of the year. And part of what I want to do, and I hope the participants of this meeting hold me accountable for this, is to ensure that we reach out to the stakeholders of the WHO, not the shareholders. The shareholders of the WHO are governments, member states, and their opinion matters, and the WHO's opinion matters. But I really want to go to civil society, to communities, to partners, to the private sector, and ask, what do you want from the WHO? What's the role of the WHO in the future? And what's the role of it as the landscape and ecosystem changes and as we take into account the lessons we've learned? What's the role of the WHO in Africa when you have a really strong Africa CDC? It changes. And I think we need to be looking to the future to understand the role of the organization and therefore the role of the foundation to help move it in that direction. I do think in terms of areas of focus, structural racism and institutional discrimination is high on my agenda. At least as a hypothesis. So is climate, and not just being responsive to climate change, but to asking, how do we as a health community prevent climate change? Just as we tackle tobacco, recognizing the ill effects on health it caused, I think we have to ask ourselves the question, should we be more aggressively engaging in looking at what's driving climate change? And these are uncomfortable questions because it means the air travel we all take. It means the food that we eat and not being more plant-based in our diets. It means the energy we consume. But can we look at the health effects of climate change and what drives climate change, and from a health point of view, actually work on reducing climate change? I also, of course, think primary healthcare matters. As Jeremy mentioned, we've been relying on vertical health programs. Primary healthcare is the part of the answer to that, and making sure that we have really robust health systems that are strong at the local level, so that people aren't put in a position of vulnerability when they can't go to a clinic or a hospital, because we're focusing on prevention, we're focusing on primary healthcare, we're focusing on community health workers. And lastly, digital health, which as a term I think is unusual because we don't talk about digital banking. Banking is just digital now. And thinking about how health needs to go from analog to digital in terms of how we deliver services and how we analyze data to be more responsive to health conditions. I have a friend who helped found an organization called Kinsa Health Thermometers, but all of the thermometer data goes to the cloud. And there was a beautiful New York Times op-ed piece last year which showed how their thermometer data predicted, and it's a hard word to use, and so I'm please, epidemiologists in the room, don't hold me accountable for that, but essentially it showed patterns in terms of fever spikes that could help public health authorities respond to where we're going to see new infections of the pandemic next. So thinking about how to use those tools is incredibly important. And the last bit I'll share, if we have a couple more minutes, is return-seeking capital. And this doesn't make me the most popular person in Geneva, but the public health sector is not only public sector. The health sector, consists of return-seeking capital, investing in infrastructure and investing in service delivery. And rather than be uncoordinated about that, one of my hopes is that the WHO Foundation can engage in the mobilization and deployment of return-seeking capital and make sure that that capital is aligned with health sector strategy and with the economic development of countries around the world, so that it's going to local organizations, SMEs, that are helping to deliver health services and be part of a public-private response and effort to build resilient and strong health systems. So those are a few of the priorities that I'm thinking about in this new role.
Well, that sounds great. And I have to tell you, I've always thought the health sector in developing countries was never given enough shrift as a real economic means to develop a country and to weigh into that. Jeremy, I would put you on the spot for that, but I won't. What I would like to do is just ask you if you have any parting thoughts, you and Anil, before we leave today.
Boy, I could go in a lot of different directions with that. I just think there's a phrase that I'm quoting a lot right now, and it's something that Amanda McClellan, who works for Resolve to Save Lives, has said, She's she's just a brilliant on pandemic policy issues, pandemic strategy issues, and she said, with respect to vaccines, we need to make sure that we're not blinded by the light at the end of the tunnel, which is to say, the vaccines are coming. They're actually amazing. If you'd said a year ago that at this point we would have not just one vaccine, we'd have multiple vaccines that worked. We'd have multiple vaccines with impressive efficacy numbers, such that we feel like the 70 to 80% efficacy is kind of a bummer because we've got others that are 90 to 95. It's amazing. But it's going to take time because the world is also trying to build a vaccine distribution and production architecture for somewhere in the range of 14 to 18 billion doses on an infrastructure normally built to produce 4 billion a year. And so it's going to take some time to get to global scale. And I think in the meantime, we really can't take our eye off the ball for preventing transmission, supporting countries and supporting communities to prevent transmission and improve treatment in the year ahead, because we will probably we'll probably see more lives saved through things like oxygen treatment and good clinical care over the coming year than we will through vaccines. And so I think we just need to make sure that collectively, as we as development professionals are thinking about how can we provide the best support to the world, it really is a both and strategy over the coming year. Yes, push hard on vaccines. Yes, advocate. Yes, hold everyone's feet to the fire on that. But at the same time, let's continue to do all we can. The world is tired. Everyone's tired of distancing measures. Everyone's tired of what we've all been through over the past year and a half. But I think what we're seeing, what we see with some of these new variants is there is real risk to in any way letting our guard down. So we really need to keep our guard up and continue pushing to reduce transmission and improve clinical care, even as we push hard to roll out vaccines more quickly.
Thank you. And Anil, I will probably say that your last remarks were so beautiful. I will not have you do concluding remarks because I've been a bad moderator and we've gone into overtime now. So thank you both. In 5 months on the job, I feel like the world is in better hands. And thank you again for being here at our conference.
Thanks very much, Anne. Bye-bye.
Thanks so much.
Bye-bye.